Hey everyone, we are going to go over Chapter 22, Nursing Management of the Postpartum Woman at Risk. We'll start with Healthy People 2030 objectives. The first one is to increase the proportion of adults with major depressive episodes who receive treatment. This will help foster the need for early identification of risk factors and prompt intervention to reduce the potential negative outcomes of pregnancy and birth. It will also help minimize the devastating effects of complications during the postpartum period and the woman's ability to care for her newborn. Now, the second objective is to reduce maternal deaths. This will help to contribute to lower rates of maternal mortality by focusing on thorough risk assessments in the postpartum period of potential infections and postpartum hemorrhage. These are the common postpartum disorders that we will discuss further on the next slides, but just to give you a heads up, these are what we are going to be discussing. So this is actually in your book, but it's clinical manifestations of shock due to blood loss. Now remember, it takes a lot of blood to actually show, for the mom to actually show that she is hemorrhaging. So these are kind of signs and symptoms. So mild, that's 20% of blood loss. You will see diaphoresis, increased capillary refilling, cool extremities, maternal anxiety. For moderate blood loss, or moderate degree of shock, 20 to 40% blood loss, you will see tachycardia, postural hypotension, and oliguria. For severe shock, that's greater than 40% of blood loss, you're going to see hypotension, agitation, confusion, and hemodynamics instability. And it's very important to know the difference in these because that way you'll know roundabout what those signs and symptoms are. You need to be looking at those early signs and symptoms to make sure we don't go to the severe signs and symptoms. Postpartum hemorrhage can occur after both vaginal and C-sections. Normal blood loss is 500 milliliters or less following a vaginal birth, and less than 1,000 milliliters following a cesarean birth. In postpartum hemorrhage, of course, it's greater than 500 and greater than 1,000 for a cesarean birth. It is the leading cause of maternal death, accounting for about 25% of all maternal deaths worldwide. The majority of these deaths occur within 4 hours of childbirth. So you see how important it is to be looking at those early signs and symptoms. Yearly, about 14 million women suffer from postpartum hemorrhage, or around 1 in 20 births. It's estimated that 90% of maternal deaths secondary to postpartum hemorrhage are preventable, and it's our job as nurses, because we're with them and we're going to be watching them and seeing all the things. So postpartum hemorrhage is defined as a cumulative blood loss greater than 1,000 milliliters with signs and symptoms of hypovolemia within 24 hours of birth. Sequelae include organ failure, shock, edema, thrombosis, acute respiratory distress, sepsis, anemia, intensive care admissions, and prolonged hospitalization. If there's blood loss occurring within the first 24 hours of delivery, it is called primary or immediate or early postpartum hemorrhage. This is when we want to diagnose that. Blood loss that occurs 24 hours to 12 weeks after birth is termed delayed or late postpartum hemorrhage. So the causes of postpartum hemorrhage, the most common cause is uterine atony. That is failure of the uterus to contract and retract after birth. The uterus has to remain contracted to control bleeding from the placental side. Any factor causing the uterus to relax can cause bleeding, even a full bladder. The muscles of the uterus contract downward, causing that blood flow to stop, also causing the placenta to separate from the uterus. So if the uterus does not contract, it will cause excessive blood loss. So typical signs of hemorrhage, you're going to see falling blood pressure, increasing pulse rate, and decreasing urinary output. These signs normally do not appear until as much as 1,800 to 2,100 milliliters of blood has been lost. This is due to the maternal blood volume increasing as much as 50% during pregnancy. Also, of course, lacerations of the genital tract can cause postpartum hemorrhage, episiotomy, retained placental fragments. That's why we have to look at the placenta after it has been delivered to make sure that there's none left inside. Uterine inversion, coagulation disorders, and hematomas of the vulva, vagina, or subperitoneal areas. This is never a good sign. Never a good sign. So the 4 T's for the pathophysiology of postpartum hemorrhage is tone, tissue, trauma, and thrombin. Talking about tone, we're talking about uterine atony or a distended bladder. A uterus with sufficient tone can clamp down on itself to constrict the uterine blood vessels. That is to clot that abnormal bleeding. Altered uterine tone commonly results from overdistension of the uterus due to multiple gestation. If the baby is big, so fetal macrosomia, hydramnios, fetal abnormality, placenta previa, precipitous birth, or retained placental fragments. Other causes can include prolonged or rapid forceful labor, especially if it's been stimulated by oxytocin. If there are any bacterial toxins, so chorioamnionitis, endometritis, and septicemia. Use of anesthesia, especially halothane and magnesium sulfate, used in the treatment of preeclampsia. Now, tissue, the retained placenta and clots. Uterine contraction and retraction lead to detachment and expulsion of the placenta after birth. When the placenta separates from the uterus, the classic sign is a small gush of blood with the lengthening of the umbilical cord, and then a slight rise of the uterus and the pelvis. Complete detachment and expulsion of the placenta allow the uterus to contract and occlude the blood vessels. But if all of the placenta does not detach or it remains inside of the uterus, it occupies space that prevents that uterus to completely clamp down. Clots will also do this too. This is why a thorough assessment of the placenta has to be completed after birth to make sure it is all attached. Now, subinvolution refers to incomplete involution or shrinking of the uterus. This happens when the muscle fibers of the uterus do not contract effectively, causing relaxation. We do not want that uterus to be relaxed. Causes, of course, retained placental fragments, distended bladder, uterine myoma, and infection. The postpartum fundal height, the 1 finger breadth per day, that is higher than expected with a boggy uterus. The lochia fails to change colors from red to serosa to alba within a few weeks. Now, trauma, vaginal, cervical, or uterine injury. This damage to the genital tract can occur spontaneously or through manipulations during birth. So with forceps or vacuum, or if the baby has shoulder dystocia and we're in there trying to move that baby around. All of those manipulations can cause lacerations and hematomas, both internally and externally. Hematomas present as pain or as a change in vital signs disproportionate to the amount of blood loss. the blood is pooling inside of the hematoma, so you're not going to actually see that blood because it's basically inside the hematoma. Uterine inversion happens when the top of the uterus collapses into the inner cavity due to excessive fundal pressure of pulling on the umbilical cord. Now, uterine rupture signs include pain, fetal heart rate abnormalities, and vaginal bleeding. Trauma can also occur after prolonged or vigorous labor, stimulation with oxytocin or prostaglandins, and after extrauterine or intrauterine manipulation of the fetus. So you see how much more high risk it is to actually induce or augment labor with oxytocin or prostaglandins, because it'll just increase that risk. Cervical lacerations can occur during a forceps delivery, or if mom starts to bear down before that cervix is fully dilated. Vaginal sidewall lacerations are associated with operative vaginal births, but they may occur spontaneously, especially if the fetal hand presents with the head. Lacerations can also happen during manipulations to resolve shoulder dystocia. So you're always going to suspect a laceration if the uterus is contracted, but bright red blood continues to trickle out of the vagina. Now, thrombin, or coagulopathy, inherited or acquired bleeding disorders, and lack of coagulating factors. Thrombosis is the formation of a blood clot, which helps to prevent postpartum hemorrhage immediately after birth by providing hemostasis. Fibrin deposits and clots in the supplying vessels. Disorders that interfere with clot formation can cause postpartum hemorrhage. Abnormal results typically include decreased platelet and fibrinogen levels, increased prothrombin time, partial thromboplastin time, fibrin degradation products, and prolonged bleeding time. Now, thrombotic thrombocytopenic purpura. This is an autoimmune disorder of increased platelet destruction caused by autoantibodies. And there is a decrease in the number of circulating platelets in the absence of toxic exposure or disease. And medical treatments of this are glucocorticoids and caplacizumab. Von Willebrand disease is a congenital bleeding disorder that is inherited. It is characterized by prolonged bleeding time, a deficiency of the von Willebrand factor, and impairment of platelet adhesions. The most common symptoms of this include bleeding gums, easy bruising, menorrhagia, blood in urine and stools, nosebleeds, and hematomas. Now, disseminated intravascular coagulation, this is a big one. This is life-threatening. It is acquired coagulopathy in which the clotting system is abnormally activated, resulting in widespread clot formation in the small vessels throughout the body. It leads to depletion of platelets and coagulation factors. It's also a secondary diagnosis, which occurs as a complication of placental abruption, anaphylactoid syndrome of pregnancy, intrauterine fetal death with prolonged retention of the fetus, acute fatty liver of pregnancy, severe preeclampsia, HELLP syndrome, septicemia, and postpartum hemorrhage. Clinical features, you're going to see petechiae, ecchymoses, bleeding gums, fever, hypotension, acidosis, hematomas, tachycardia, proteinuria, uncontrolled bleeding during birth, and acute renal failure. Treatment is blood products, coagulation factors, and making sure that you are identifying and treating the underlying cause. So traction is pulling of the umbilical cord after the birth of the fetus to extract the placenta before it's completely separated from the uterine wall. Do not do this. It can absolutely result in massive hemorrhage, and you do not want that to happen. This is just a cute little picture. You know how I am. As the nurse, you are going to be assessing for risk factors, which they are in table 22.2. Begin by reviewing her history. Postpartum hemorrhage is often unanticipated, but you know, it can definitely happen. You're going to be assessing for uterine tone, any vaginal bleeding. The tone you're going to assess after birth by palpating the fundus for firmness and location. The soft, boggy fundus indicates uterine atony, which is never good. So it also needs to be in the midline position and firm. Always follow your hospital policy for monitoring vaginal bleeding. You're going to be assessing for hematomas. You're going to look for a localized bluish bulging area just under the skin surface in the perineal area. Mom is usually going to report a severe pain and have difficulty voiding. You may see hypotension, tachycardia, and anemia. So nursing management, if the initial steps do not fix the uterine atony, you may have to have more aggressive interventions, such as by manual compression, internal uterine packing, and or a balloon tamponade. So fundal massage, pad count, those are your first line treatments. Also see nursing procedure 22.1. The massage will stimulate the muscle fibers to contract. You're going to use a circular motion, and you're not going to over massage, as this can lead to uterine fatigue. Also, you may be administering uterotonics. So an injection of a uterotonic drug immediately after birth is an important intervention used to prevent postpartum hemorrhage. So oxytocin or pitocin, misoprostol or cytotec, dinoprostone, that's Prostin A2, methyl ergonovine maleate, which is methergine, and a derivative of prostaglandin 2, which is PGF2 alpha, and carboprost, which is hemabate. Now, misoprostol is not approved by the FDA for this purpose, and it would behoove you to see Drug Guide 22.1. Now, pitocin, you're never going to give that undiluted as a bolus injection intravenously. It needs to be piggybacked into a primary line. Cytotec, there is an increased risk for allergy. You cannot give if they have active cardiovascular disease, pulmonary or hepatic disease. Methergine, if the woman is hypertensive, do not administer. With hemabate, it is contraindicated with asthma due to risk of bronchial spasm. Also, you're going to administer fluid. You're going to maintain that primary IV infusion. Be prepared to start a second infusion. She needs to have had a blood draw for type and cross match. Hopefully that was done beforehand, but that needs to be done ASAP. You're going to monitor for signs and symptoms of shock. You're going to check vitals every 15 to 30 minutes, monitor CBC, monitor level of consciousness. Foley needs to be in place to avoid displacement of the uterus. Make sure those placental fragments are removed. They are usually manually separated and removed by the healthcare provider. Emergency measures if DIC occurs, replace fluid volume, administer blood components, optimize oxygenation and perfusion status. Prevention, avoiding episiotomy unless it's an emergency. You'll see a lot of times these healthcare providers would rather her just tear on her own. Make sure you're inspecting that placenta for completeness. And the 4 R's are tenets in reducing preventable maternal morbidity and mortality. This is readiness, recognition, response, and report. This is a cool little picture I saw that thought you might like. So thromboembolic conditions, basically it's the inflammation of the blood vessel lining. There are 3 common types. So venous thromboembolism is one of the leading causes of maternal mortality and morbidity. It has an annual incidence of 1 per 1,000 pregnancies, which is a risk 10 times higher than that of non-pregnant women. So just by being pregnant, that risk is 10 times higher. So thrombosis is a blood clot within a blood vessel causing inflammation of the blood vessel lining, thrombophlebitis, which can turn into a thromboembolism, which is the obstruction of a blood vessel by a blood clot carried by the circulation from the site of origin. So superficial thrombosis is usually confined to the saphenous vein in the lower leg, and it can be caused by the use of the lithotomy position during birth. That's why you want her up and moving. It's never a good sign to keep her in that lithotomy position the whole time. Deep vein thrombosis. This may cause a pulmonary embolism. It can involve deep veins from the foot to the calf, thighs, or pelvis. These have a high probability of moving and causing pulmonary embolism, which may cause chest pain, breathlessness, and sudden death. Usually it is clinically silent, but can cause calf pain, edema, and venous distension. So the pathophysiology, basically the thrombus formation results from venous stasis, injury to the innermost layer of the blood vessel, and hypercoagulation related to pregnancy. And approximately 600,000 pulmonary embolisms occur yearly in the United States, resulting in 60,000 to 100,000 deaths. Here is a picture of a superficial thrombosis. This kind of explains a DVT and embolus. This shows you what can happen with a pulmonary embolism. Never, ever, ever good with these. So you are going to be assessing risk factors. Some of the risk factors, use of oral contraceptives before pregnancy, it can absolutely increase their chance of a thromboembolic condition. Smoking, employment that necessitates prolonged standing. If she's had a history of thrombosis, thrombophlebitis, or endometritis. Evidence of current varicosities. Also prolonged bed rest, diabetes, obesity, cesarean birth, progesterone-induced distensibility of the veins of the lower legs during pregnancy, severe anemia, varicose veins if mom is older than 34, and multiparity. The likelihood is increased during pregnancy and for approximately 12 weeks after childbirth, partly due to the increased platelet stickiness and also partly due to reduced fibrinolytic activity. So even 12 weeks after she has given birth, that likelihood is increased. So signs and symptoms you're going to be looking for: pain or tenderness in the lower extremities. If the area appears reddened along the vein and it is warm to the touch. If there is increased pain in the affected leg when they're ambulating or bearing weight. A DVT is more common in the left lower extremity, presumably due to the compression of the left iliac artery. You may see calf swelling and tenderness, difference in leg circumference, erythema, warmth, tenderness, pain with calf pressure, and pedal edema may be noted. Now, for a pulmonary embolism, you need to be alert for unexplained sudden onset of shortness of breath and severe chest pain. She may appear apprehensive and diaphoretic. She might have distension of the jugular vein, decreased oxygen saturation, cardiac arrhythmias, tachypnea, tachycardia, fever, hemoptysis. There may be a sudden change in mental status as a result of that hypoxemia. So as the nurse, prevention is the biggest. So encouraging activity that causes leg muscles to contract and promotes venous return. That's walking. So early ambulation, always the best. Leg exercises as well. So dorsiplantar flexion of the feet. If she has prolonged sitting, intermittent sequential compression devices to produce passive leg muscle contractions until she is ambulatory. So especially moms that have had an epidural or a block and they cannot get up. Elevating legs above heart level to promote venous return. Stopping smoking, of course, to reduce or prevent vascular constriction. So not only does it constrict your vessels, smoking, but it also makes your blood thicker. Applying compression stockings and removing them daily for inspection of legs. Using post-operative deep breathing exercises. That's going to help reduce the chance for pulmonary embolism. Maybe using aspirin or anticoagulation therapy to reduce that coagulability, words are hard, not crossing legs for long periods and not leaving legs up in stirrups for long periods. Also, the stirrups need to be padded to reduce the pressure against the popliteal angle. Avoid sitting or standing in one position for prolonged periods. Avoiding trauma to the legs to prevent injury to the vein wall. Increasing fluid intake to prevent dehydration, and avoiding the use of oral contraceptives. So the easiest and most cost-effective method to prevent these conditions is early ambulation. Also, a low molecular weight heparin, such as enoxaparin, Lovenox, can be given, as can rivaroxaban, which is Xarelto, apixaban, which is Eliquis, or dabigatran, which is Pradaxa for prophylaxis. Typically, it is discontinued during labor and birth and restarted during the postpartum period. Adequate circulation, NSAIDs, bed rest, anti-embolism stockings, anticoagulation therapy, all these things can help. So education, you can see the teaching guidelines 22.1. If they are on anticoagulant therapy, these are important. Encourage her to notify the provider if she sees nosebleeds, bleeding from the gums or mouth, black tarry stools, brown coffee ground vomitus, red to brown speckled mucus from cough, if there is any oozing at the incision or episiotomy site, or if she cuts herself or scrapes herself, if there's pink, red, or brown tinged urine, bruises, and increased lochia discharge, she needs to notify the healthcare provider. Also, practicing measures to reduce the risk of bleeding, such as brushing the teeth gently, using a soft toothbrush, using an electric razor for shaving instead of a straight razor, avoiding activities that could lead to injury, scrapes, or cuts, not using over-the-counter products containing aspirin or aspirin-like derivatives if they are on coagulation therapy, avoiding alcohol, and making sure to inform other healthcare providers about anticoagulant use. So dentists, anyone like that. Make sure that they are complying with lab testing. So if they are taking warfarin, they're going to have their blood drawn often to make sure that they are not too thin, not too thick. If they are accidentally cut, apply firm, direct pressure to the site for 5 to 10 minutes. Do not do the same if you're having an injection or a lab draw. Wearing an identification bracelet or band that indicates that you are taking an anticoagulant. Eliminating modifiable risk factors such as smoking, oral contraceptives, a sedentary lifestyle, and obesity. Understanding the importance of using compression stockings. Avoiding constrictive clothing and prolonged standing or sitting in a motionless, leg-dependent position. And knowing the danger signs to report to providers such as a sudden onset of chest pain, dyspnea, and tachypnea. Now, postpartum infections, this is a very common cause of maternal morbidity and mortality. Postpartum infections are estimated to occur in up to 8% of all births and accounts for 15% of global maternal mortality. There's a higher occurrence in C-sections. It is defined as a fever greater than 38 degrees Celsius or 100.4 degrees Fahrenheit after the first 24 hours of birth, and it occurs on at least 2 of the first 10 days after birth, exclusive of the first 24 hours. So risk factors, of course, a surgical birth, prolonged rupture of membranes, long labor with multiple vaginal examinations. That's why you definitely do not want to have multiple vaginal examinations while she's there and in labor. Inadequate hand hygiene, that's always going to be an issue in the real world. Internal fetal monitoring, uterine manipulation, chorioamnionitis, instrumental birth, so vacuum or forceps extraction, obesity, untreated infection prior to birth, if retained placental fragments, obesity, gestational diabetes, which is always going to increase your risk of infection, extremes of client age, so very young, very old, low socioeconomic status, and anemia during pregnancy. Postpartum women who are at increased risk for infection due to tissue trauma during birth, vulnerability from the placenta separation site, and also that incision from the cesarean section. Also, normal physiological changes of childbirth decrease the vaginal acidity due to the presence of amniotic fluid, blood, and lochia, all of which are alkaline, and alkaline environments encourage the growth of bacteria. So signs and symptoms you may see: elevated temperature, general malaise, pain, chills, increased pulse rate, abdominal pain, and malodorous lochia. Organisms, usually those of the normal vaginal flora, so generally from Staphylococcus aureus, Escherichia coli or E. coli, Klebsiella, Gardnerella vaginalis, Gonococci, coliform bacteria, group A or B hemolytic streptococci, Chlamydia trachomatis, and anaerobes that are common to bacterial vaginosis. So metritis is the infection of the endometrium, decidua, and adjacent myometrium. It is a uterine infection that typically develops within 2 to 4 days postpartum to as late as 6 weeks. It is an infectious condition involving all of the things of the uterus. The uterine cavity is sterile until the rupture of the amniotic sac. It is then contaminated by bacteria that normally reside in the bowel, vagina, perineum, and cervix, such as E. coli, Klebsiella, or G. vaginalis. There is a higher incidence in C-sections, and that is why normally women will be getting a 1 dose of prophylactic antibiotic 1 hour before any C-section. Wound infections are any break in the skin or mucous membranes. They provide a portal for bacteria. So sites can include cesarean surgical incisions, absolutely the episiotomy site in the perineum, and genital tract lacerations. These are usually not identified until the woman has been discharged, as symptoms may not show up until 24 to 48 hours after birth. Urinary tract infections are also common, usually caused by bacteria from the bowel, E. coli, Klebsiella, Proteus, and Enterobacter. Urinary catheterization, frequent vaginal exams, and genital trauma will increase mom's risk, causing urinary frequency, urgency, dysuria, and lower abdominal pain. Now, mastitis is the inflammation of the breast, the inflammation of the mammary gland, and it may occur within the first 2 days to 2 weeks postpartum. And up to 10% of breastfeeding women will develop mastitis. The risk factors include stasis of milk due to infrequent, inconsistent breastfeeding, if mom has had previous episodes of mastitis, and if she has nipple trauma. It's very, very, very uncomfortable, and it can cause the mom to stop breastfeeding. It can be caused by insufficient drainage of the breast, rapid weaning, if there's an oversupply of milk, pressure on the breast from a poorly fitting bra, a blocked duct, missed feedings, and breakdown of the nipple via fissures, cracks, or blisters. It usually is caused by Staph aureus coming from the infant's throat. Flu-like symptoms are often the first symptom experienced. The breasts are red, tender, and hot to the touch. The upper outer quadrant of the breast is the most common site for mastitis to occur. So treatments are effective milk removal, pain medication, and antibiotic therapy. This is just a picture of the inflammation of the endometrium or endometritis. This is an infection of an episiotomy. That hurts me so bad, I want to cry. This is a picture of mastitis. Clearly, you wouldn't want to breastfeed your child because it would hurt so freaking bad if you had this going on with your breast. So therapeutic management, of course, is broad-spectrum antibiotics for mastitis, along with fluid and electrolyte balance, analgesia, and emotional support. Wound care for wound infections needs to be sterile and frequent. Good hand hygiene, frequent perineal pad changes, hydration and ambulation, and parenteral antibiotics. For UTI, you're going to increase fluids, give antibiotics. Also, large doses of vitamin C and cranberry juice will help. For mastitis, breast emptying and antibiotics, and also increasing the frequency of nursing. Prevention is key. Using aseptic technique with anything, hand washing, perineal hygiene, invasive procedures such as catheterization and changing surgical dressings needs to be totally sterile. Also screening visitors to make sure that they stay away if they're sick. Administering antibiotics, wound care, teaching, making sure that she continues her antibiotics as ordered and finishes it. Calling the healthcare provider if her temp is greater than 100.4. Watching for chills, increased abdominal pain, handling the perineal pad by the edges, not touching the inner aspect of that pad. Angling the peri bottle to spray from front to back. Drinking plenty of fluids, taking vitamins, eating a healthy diet, and adequate rest. This is the method for assessing the perineum. So it's called REEDA, and it is another one of the scored type things that we do when we are assessing the healing. Postpartum baby blues. Up to 85% of women experience some type of mood disorder due to plummeting levels of estrogen and progesterone immediately after birth. Reproductive hormones influence every biologic system. 80% of women experience the blues. Okay, blues typically peak on postpartum days 4 and 5. and usually resolve by postpartum day 10. And up to 20% of women with blues go on to develop postpartum depression. This is just kind of a side-by-side of baby blues as compared to postpartum depression, because it is a totally different, okay? So signs of postpartum depression. So this is a form of clinical depression affecting women and sometimes men after childbirth. It affects as many as 1 in 9 women. They feel worse over time. They have changes in mood and behavior that do not go away on their own. It may persist for a minimum of 6 months if it's untreated. It usually has a gradual onset, and it usually becomes evident within the first 6 weeks. So the levels of estrogen, progesterone, serotonin, and thyroid hormone decrease sharply and return to normal during the postpartum period. It can also be caused from unresolved feelings about the pregnancy, fatigue after delivery from lack of sleep or broken sleep, feelings of being less attractive, inadequate assistance from a partner, which is absolutely a thing, lack of social support network, history of sexual or physical abuse, unemployment or financial insecurity, doubts about being the ability to be a good mom, stressful life events, relationship issues, stress from changes in work and home routines, and loss of freedom and old identity. Now, signs and symptoms you may see: restlessness, worthlessness, guilt, hopelessness, moodiness, sadness, being overwhelmed, the loss of enjoyment, low energy levels, the loss of libido. You may see her crying a lot, exhibiting a lack of energy and motivation, being unable to make decisions or focus, losing her memory, experiencing lack of pleasure, having changes in sleep or weight, showing a lack of concern for herself, withdrawing from friends and family, having pains in her body that do not subside, feeling negatively toward her baby, experiencing appetite disturbances, feeling isolated from others, a lack of interest in her baby, worrying about hurting the baby, acting detached toward others and the infant, and having recurrent thoughts of suicide and death. So this is the Edinburgh postpartum depression scale that you can kind of go over, and then this is how it is scored. This is done on every single woman, just to get an idea if they are at risk for postpartum hemorrhage. Now, postpartum psychosis, this is never good. This is an emergency psychiatric condition, and it can result in a significant increased risk for suicide and infanticide. It occurs in 1 of 1,000 live births. It can occur at any time in the first year postpartum. Onset can be abrupt and unexpected, though a previous history of mental illness is common with this. So the symptoms are mood lability, delusional beliefs, hallucinations, disorganized thinking, sleep disturbances, fatigue, depression, hypomania. She'll be tearful, confused, preoccupied with feelings of guilt and worthlessness. These can escalate to delirium, hallucinations, extreme disorganization of thought. Never, ever, ever leave these women alone with their infant. Most are hospitalized for up to several months, and psychotropic drugs are almost always part of the treatment, along with individual psychotherapy and support group therapy. Assessment is key. So making sure that you start early, reviewing symptoms with the mom and the partner. If she does have a history of mental illness, that will absolutely increase her risk for postpartum depression and or psychosis. Is the following statement true or false? Postpartum hemorrhage is most commonly due to uterine atony. It is true. Which drug would the nurse expect to administer to a postpartum woman with deep vein thrombosis? The answer is heparin. This is given to reduce the risk of further clot formation. True or false? Postpartum psychosis is the most severe form of postpartum affective disorder, and the answer is true.